Hello and welcome to Sick Notes. My name's Ed Hope. I'm a junior doctor working in emergency medicine in the UK, and on this channel I like to talk about hospitals, the human body, general medical things, and explain it in simple terms. Something crazy amazing happened last week. As you guys know, I'm a big fan of Scrubs. It inspired me and probably many of other people to consider medicine in the first place, and the show's creator Bill Lawrence checked out one of my previous reviews and gave me a little tweet of support. Let me have a quick read to you. Hey, really enjoyed your review of our show. That rabies case was based on a real case. Giant bummer. Yeah, so a few of you commented in the comments of the video about that crazy case to think that actually happened. It goes on to say, you reminded me of always talking to my best buddy, the medical advisor on the show, and a cardiologist here. His name is John Doris, real JD. Thank you so much, Mr. Lawrence, for that. I really appreciate the sort of watching the video and giving me a shout out. So with Mr. Bill Lawrence's blessing, I thought I'd check out another classic episode of Scrubs, and the one you guys have been throwing around at me has been My Old Lady from season 1. Now I remember a little bit about this. This is where JD, Turk and Elliott get their first glimpses of death as a doctor. So as always with these reviews, it's just gonna be a light-hearted look. I'm not expecting it to be super accurate. It's just a chance to revisit the episode, talk about a little bit more what's happening on screen, and to share some of my experiences. So let's get on with it. I'm no Superman.
On my first day, my resident told me, if you don't count the maternity ward, which is mostly, well, you know, or the emergency room, which is mostly broken bones, stitches, you know, that sort of thing. He said that 1 out of every 3 patients that's admitted to this place will die here.
Wow, is that statistic true? Sounds a bit high to me. I like the sentiment about the maternity ward actually. When I worked as an obstetric junior doctor, that was one of the best things about the job, was that it was kind of 100% positive. Like, people came in who were normally well, and they had this, it was not only such a special day of their life, it was often the first day of people's lives. The flip side of that is that when stuff does go wrong, it can be even more devastating because you don't expect something to go wrong in something that is essentially, you know, a normal part of life.
Hello. I'm the doctor. I'm the doctor.
What are you, 16?
Oh, this is unacceptable.
Yeah, I mean, young-looking doctors, I guess in any profession, if you're blessed with youthful looks, then you'll often have to deal with a prejudice that people don't think you're old enough to do the job.
He's young, but he's probably a very good doctor. Are you a good doctor?
Kind of too soon to tell.
Honesty. Well, I like that. You probably want these people to wait outside.
That'd be nice.
Make them know you're a man, not a boy.
So one of the things I love about doctoring is shown here. Is that the right word? You know what I mean. Being a doctor is you have to kind of use every facet of your personality. Sometimes you have to be quite sensitive, and sometimes you have to, you know, kind of put your presence out there to get things done. You don't always get it right, and it does take time to develop that. And it's probably common to a lot of jobs actually, but it's really about stage managing your clinical space. So making sure the patient and the relatives feel comfortable and confident in what you're doing. You know, often has no bearing on your clinical experience, but they just feel more at ease in that setting. You know, even if it is just asking them to sit outside.
Everybody out of here now!
To wake up the dead.
Now.
I say this is a simple laparoscopic hernia repair, sir.
Oh, see, this is embarrassing. You guys are wearing the same outfit.
Great, moving on.
Where are you guys going?
So then we see Turk on a surgical ward round, and this is pretty much how fast a surgical ward round can be. People wonder why us doctors' notes are often really badly written, but there's no real excuse for that. But certainly what doesn't help is when we have to deal with, you know, documenting at a super quick rate. Turk's patient is a young chap with a hernia, a super common condition you've probably all heard of. Now, a hernia in medical terms just means any tissue or organ that protrudes through into a different space. In this clinical context, we're talking about the abdominal wall, so the tummy muscles, and there's often a small weakness there that the tissue or organs beneath it get pushed through. So in this context, my thumb is going to be the bowel pushing through. Generally speaking, hernias are not huge issues. They do need to be surgically repaired, but can often wait. So you may have heard of sports people getting hernias but waiting till the off season before they become repaired. They may sometimes need to be repaired as an emergency if this hernia gets stuck and is unable to be pushed back through. This is called an incarcerated hernia. This can stop the bowel working, what we call bowel obstruction, or even worse, cause strangulation. So as it's pushed through, the blood vessels that supply that part of the tissue of the bowel become compromised and can lead to the tissue dying. So this is why it can be an emergency.
I called down and requested a Spanish-speaking nurse. So no English, huh?
We move on to Elliott's patient who can't speak English. This is super relevant. I see this pretty much on a daily basis. Frequently, you can rely on family members to help give a history, but in an emergency setting, particularly with injuries, you have to get a hospital translator or another healthcare professional that can speak the language to translate, just to rule out any kind of domestic violence or anything that may have caused the injury.
Mrs. Guerrero is a 40-year-old lupus patient who presented with shortness of breath, so I started her on a heparin drip and ordered a VQ scan. Just wanted to run that by you.
So Elliott's patient has come in with a flare-up of lupus. So House famously said it's never lupus, but we know it is in this particular episode of Scrubs. For those of you who don't know, lupus is a long-term autoimmune condition, which means your immune system ends up attacking your own tissues and organs, causing inflammation. Now, it's a spectrum of disease, so people may just be well medicated on it and just feel tired with it, or the extreme end, people can have these flare-ups, which means they're in and out of hospital with fevers and the disease affecting, pretty much every kind of organ in the body. So it can attack your lungs, your kidneys, your heart, your blood vessels, your joints, and even your skin. In fact, the name of the illness, lupus, comes from the Latin of wolf, because the skin lesions can be so severe that they look like a kind of wolf's bite.
I feel like you're missing out. Like this Miss Tanner, she's got this incredible energy and warmth.
So I've said it with several of these reviews that I've done, that you do get these patients that you really connect with, and it doesn't happen with everyone. It kind of happens for me kind of on like a weekly basis, really. Clearly it happens more in these shows because that's a really interesting thing to explore as part of the story. But when you do, in A&E, I'm generally with patients for no more than 4 hours, but in that time it can be such an anxious part of their lives that you can get to know people really quickly. And some people I will then, if they get admitted to hospital, come see them, while on the wards while they're still there. And not only do you get to know people quickly, you kind of get to know them perhaps in a way that not many people have known them before, like through this difficult time. So, that's really one of the ways that it is real privilege and a pleasure to do what we do. This is pretty much the exact opposite relationship I have with the domestic staff in my hospital. Thankfully, they're not trying to kill me, or maybe they're sneakily doing it and just hiding it by being nice to me.
Find her.
This is Tanner.
Here's the party.
Look, I don't know how it's been with your other doctors, but when you're under my care, you stay in the hospital until I say it's okay for you to leave.
We saved your plate.
Yeah, traditionally the doctor would kind of make the plan and the patients kind of obey the plan. But we've kind of moved away from that. It's much more about shared decision making, informing the patient and making a plan together. When people are in hospital though, and acutely unwell, there's very often one well-trodden route that we'll do first. And so it is more laid out. But then sometimes you do get people resistant to that. I think it's because often it's a bit of denial, because they associate with being unwell with being in the hospital, and they just want to get out the hospital because then they feel like they'll no longer be unwell. And they'll often make excuses like, well, I've got this at work to do, or I'm going on holiday and I can't miss this, and things like that. And it can be frustrating and take a lot of energy to try and help them help them overcome their fear and come to the right conclusion. And sometimes you don't. And that can be really frustrating because you feel like, you know, I'm taking more care of your health than you are of yourself. And, you know, what can you do about that?
Hey, come on, man. It's the fourth quarter. You got a minute?
Sure.
Cool.
David, right?
Yeah.
I'm Turk.
What's up? You want some IV?
No, I'm good.
You sure?
Turk only just introducing himself to the patient, even though he's seen him on the ward and effectively is his patient. I mean, I laugh at that, but sadly I have seen this. You know, it's just kind of common courtesy, isn't it? Let alone professional courtesy, but, you know, sadly does happen.
This is not gonna hurt as much as you think.
I'm ready.
Hospital bowling happens all the time.
I'm gonna order an ABG just to be safe. What do I think?
Yeah, that's probably a good idea.
So Elliott's having difficulty trying to come up with a plan for your patient as a junior, because this is, don't forget, very early in the Scrubs episode. This is really, really relevant and what pretty much your whole first couple of years are like, because even when you make some decisions that, you know, you're then comfortable with, there's another load of decisions waiting for you to then be indecisive about. But this isn't necessarily a bad thing. When medical students talk to me about having these issues, I always say to them, you know, being a conscientious doctor at first, that is a good thing. You know, that shows you are a safe doctor. So Turk's hernia is having keyhole surgery to repair it. And they notice, unfortunately, there's more going on than they first thought, and they suspect the patient has lymphoma. So in reality, you'd actually need a sample of tissue to confirm that. So maybe they did that, but you just didn't quite see it. So lymphoma, for those of you who don't know, is a cancer of the white blood cells called lymphocytes that make up your immune system. And it can lead to tumours forming in lymph nodes and other parts of your body. So lymph nodes form part of the lymphatic system, which is kind of the sewage system in the body. So it takes, you know, fluid, protein cells that are in the tissues and distribute back up into the bloodstream. That's often where you get signs of infection that the lymphocytes can latch onto and develop their immune activity. That's how they normally work. I'm the furthest thing from an expert on lymphoma, but I do know there are so many different types, and you need to get a piece of tissue to look at it under a microscope and perform some tests so you know what treatment is likely to work well. Treatment options are generally things like immunotherapy, so giving the patient some antibodies so the body can recognize and fight the cancer, or things like chemotherapy and radiotherapy. Surgery, generally not done so much.
Her OSAT's in the 80s, and take a look at her heart rate.
So Elliott's patient with lupus has got a pulmonary embolism, or PE. Pulmonary meaning lungs, and embolism meaning something that travels through the bloodstream and then blocks a blood vessel, most often a blood clot. This is realistic because people with lupus are much more likely to get pulmonary embolism. That's because during the inflammatory process, this kind of activates the clotting in the blood. And also, we talked about earlier, you can get, in lupus, you can get damage to the blood vessels, which mean the blood are more likely to clot. So when you get this blood clot in the lungs, it means that the blood can't get oxygenated by the lungs, so we get breathing difficulties. And this is why the oxygen starts dropping in this case.
She seems to be decompensating, but thrombolytics scare me. I mean, a lot of times the patient bleeds out.
She needs to know what's going on.
In this scenario, you definitely get more help. The treatment is high flow oxygen with a mask, so not just with the tube or the nasal specs that are shown here. And usually in PEs, as they did in this episode, we start with blood thinning medication, but this works very slowly over days to weeks to months. But in a massive PE, so a huge blood clot, meaning lots of the blood can't get oxygenated, the patient's going to decompensate, aren't they? They're going to be unable to provide enough oxygen to their body, and that's what's happening here. So in that scenario, you actually have to give medications that break down the clot very quickly, and these are scary medications to prescribe. As shown here in Scrubs, you know, Elliott is extremely nervous about doing it. When you have to give these really powerful drugs that can have these massive side effects, so if you're stopping the blood clotting, you can cause massive bleeds to patients. That's a huge call to make. So even though it's absolutely necessary in this patient, I can totally empathise with Elliott here having to make that call. So JD's neat old lady, as he described her, has end-stage renal disease or kidney disease. For those of you who don't know, the kidneys are these kidney-shaped organs that live in your back. I normally use the really bad joke that they literally take the piss out of you. But as well as having an excretory function, their kind of main role is a regulatory function in the body. So they make sure you've got the right amount of water, that your blood's the right pH, that all the right electrolytes, so the sodium and the potassium, all these salts are the right levels. And they also help with red blood cell production as well. If without them, you'd only live days to weeks, really. So JD has the difficult job of telling the patient that her kidney disease has progressed.
Basically, your kidneys aren't responding to the medication anymore. I'm afraid we're gonna have to start you on dialysis.
I'm not a big fan of dialysis.
Yeah, unfortunately, we don't really have a choice.
Well, actually, I do have a choice.
Certain things you never expect to come out of a person's mouth.
I think I'm ready to die.
I bet a ton of bricks for Dr. Dorian.
That is brilliant. How do Scrubs do this? They sort of turn those moments that we kind of all dread, and they all happen, but they just, they make it funny, but it's never dark. It's quite sensitive, isn't it? Patient autonomy, so the right for an individual to make their own decisions on their care, is a key principle of medicine, even if as a doctor you don't think they're making the right decision.
There is no ethical dilemma.
But what about our duty as doctors to do everything in our power to help?
What about our duty as doctors? Look, this has nothing to do with the patient. It's all about you. You are afraid of death, and you can't be.
Dr. Cox is exactly right. At medical school, you think that the worst thing about being a doctor is dealing with death, and certainly the question I get asked a lot by friends is kind of how you deal with death, particularly because I worked in palliative care. But death is not the worst thing that can happen to someone. Sometimes it's the right time for someone. So as a doctor, it's not that we prevent death at all costs. Sometimes it is just about being there and, you know, being by someone when they have their last few moments. It's not always, you know, about preventing the inevitable.
I win.
Where? I don't see.
Here, diagonally.
Pretty sneaky, Dad.
Only Scrubs could get away with that kind of segue beautifully from that poignant moment to this brilliant picture of JD playing Connect 4 with Death, the Grim Reaper, and not realising that he's lost. So JD tries to create a list of things that the old lady could do with her life in a way to try and convince her to take the dialysis and to, you know, extend her life. But she says she's pretty much done all she's wanted.
What about your list? How many of those things have you done? For that matter, how many times have you sat on the grass and done nothing? You need to start taking some time for yourself, young man.
Yeah, exactly right. I mean, one of the biggest negatives in medicine, and I know it's not unique to medicine, lots of careers are like this, is the sacrifice you make. At medical school, you're really encouraged to do sports or artistic pursuits and travel and things like that. But as soon as you do the job and you're working on like a full shift rota, it's very difficult to coordinate that with other people's lives. And what they're hinting at here is really something that I've thought about a little bit, is that, you know, although, you know, medicine can help people live, it doesn't give you something to live for. You have to find other things that really, you know, make your life rich as well as just doing the job.
You're okay.
Oh, so the bittersweet song of Hallelujah, you know it's not going to end well when this starts playing.
Used to live alone before I knew you.
So we had JD's patient who we knew would die. Elliott's patient was acutely unwell with a PE, so, you know, this has a high mortality, so we're not really surprised that that happened. Turk's patient with lymphoma, however, the timeline is a little bit off. So as mentioned, the treatment would usually be things like chemotherapy and radiotherapy. Surgery doesn't really have a place, although it can be used if if the lymphome's infiltrated a particular organ. Clearly there's an artistic license at play. It's not about the accuracy at this point, it's about the feelings and what happens at a hospital when people die. And in this context, it's about showing what the doctors go through and how they're dealing with their kind of first steps of what they're going to see a lot of their career, and you know how it affects them.
So they say that 1 out of every 3 patients admitted to this place will die here. But some days the odds are worse than that.
I'm so sorry.
And on days like that, I guess the best you can hope for is that you took something from it.
Hey, I'm Turk.
Anything.
VP's 120 over 80. I like that diastolic. Let's keep it that way.
Anything at all. Even if it's just taking the time to lie in the grass and think about all the things you still have left to do.
Brilliant. I couldn't have said it better myself. Well, clearly the writers are much better at me at putting things together, but what a perfect sentiment to end on. So there we have it. I mean, I know why you guys wanted me to revisit this episode. It's pretty much perfect. I mean, something that is so funny and real and educational and, you know, incredibly moving, and all this around the subject matter of dealing with death. I mean, Bill, if you're watching, bravo, mate. And it just leaves me to say thank you guys for watching. If you enjoyed this, why not check out some of my other Scrubs reviews? I really appreciate all the support, all the comments, all the shares, all the subscribers. So until next time, look after yourself, and I'll see you soon.